Good afternoon, everyone. We apologize for the delay in starting the session. We had some technical difficulties, but we are all ready to go. My name is Natasha, and I'll be facilitating today's session along with Cassandra. Today, we're going to be covering Unit 4, which is post-service financial care. Specifically, we're going to be doing sections 4.1 through 4.4. Remember that we are recording the session. We ask that you keep your cameras off and on mute until the end, where you can unmute yourself to ask any questions. And you can also use the chat throughout the session if you have any questions. So section 4.1, cash posting and electronic remittance advice and fund transfers. In this section, we will learn about internal controls for cash handling and posting, electronic funds transfer, and electronic remittance advices.
Cash handling opens the potential for fraudulent activities and requires controls to ensure that safeguarding of cash flow. These controls include the separation of cash handling procedures whereby the same person who opens and endorses the checks is not responsible for the deposit. It also includes the establishment of internal audits outside the involved department, the routine use of outside auditors to track cash flow, the routine reconciliation of daily cash against deposits, postings, and write-offs, the use of multiple levels of authorization for refund checks, write-offs, and disbursements. Policies and procedures should segment responsibilities so that no one individual has the ability to post charges, payments, and write-offs without a balancing control. Large adjustments, write-offs, charge transfers should require a manager-level authorization. Some can email to the CFO. Many healthcare providers have eliminated mail payment delivery, though the use of bank lockbox, through the use of bank lockbox, it not only improves security, but also expedites the deposit of funds. Many are also capable of providing the deposit details in a postable 835 ERA file.
Daily reconciliation process. In order to implement an effective daily control process, policies and procedures for daily reconciliation should be developed and implemented. Policies and procedures should segment responsibilities so that no one individual has the ability to post charges, payments, and write-offs without a balancing control. Another activity to document the fund transfer, preferably by a supervisory level staff member. Large adjustments, including contractual write-offs, bad debt write-offs, and charge transfers, should require a manager level authorization. While controls may have the effect of slowing the accounts receivable processing, the lack of control can result in the loss of revenue and cash. Processing general ledger cash requires the same separation of duties, and it includes payments like cafeteria receipts, gift shop receipts, and parking receipts.
This is the electronic transfer of funds, or EFT, from payer to payee through the banking system. It is considered the fastest way to move money because it is possible to transfer funds between banks on the same day. This is a network of money movement available to banks through the Federal Reserve System. EFT balancing and controls are the use of EFT greatly simplifies cash balancing and control requirements since the cash is deposited directly into the provider's bank account. The bank informs the provider of the amount received and issues a deposit. The provider balances this to the electronic remittance advice received. The actual posting of the EFT dollars to the accounts receivable may be accomplished in a variety of methods, typically predicated on the receipt of either a paper remittance advice or an electronic remittance advice. Control logs must be maintained to ensure that all EFT deposits are posted to the patient accounting system in a timely manner, which is usually daily.
So A35, a standardized healthcare claim payment remittance advice known as the A35 is used to send payments to healthcare providers.
There are different levels of the A35. Level 1, electronic receipt of data only. An electronic remittance advice is received and the information is printed. The printout is then processed the same day as a paper remittance advice. The advantages include saving mail time for the remittance and a standardized format for data entry. Level 2 is electronic receipt and electronic data entry. With this level, the electronic remittance is received, entered into the computer electronically, and viewed on a terminal. Data entry tasks are eliminated through automated entry of the information, but usually continues to be a manual matching of remittance information to an individual account and reconciliation of charges submitted to the amount paid. Level 3, electronic receipt, data entry, reconciliation, posting, and closing. Here, the electronic remittance advice is received and entered into a computer electronically, and the remittance data are electronically posted by the patient accounting software, simultaneously updating the patient's account. Standard adjustment codes must be established to automate entries for payment, write-offs, and contractual allowances. Manual intervention is only needed if there's a disagreement or an error. And level 4, total automation of receipt, data entry, payment, posting, and adjustment processing. In addition to everything included at level 3, this level links with banking information to allow reconciliation of payments received electronically through a non-bank network with funds received electronically. Medicare logs and the secondary billing process are automated using ERA, an electronic explanation of benefits received from the primary payer is transmitted electronically with a secondary claim. Manual intervention is only required to handle disagreements.
There are many components to each payer's remittance. They include the payment amount, information on zero payments, partial payments, contractual allowances, and patient deductible and copayment responsibilities. Each transaction type must be balanced and controlled to ensure that incorrect payments are identified, incorrect contractual adjustments are identified, denials are identified, and that the patient's account reflects the correct balance. The following steps will ensure proper balancing and control of the ERA posting. So download the ERA electronic files, review payment amount with EFT payment amount, process against system filters to identify items that require manual review, such as posted contractual adjustment do not match actual payer contractual adjustment, takebacks, denials, zero payments, health claims. And after resolving all filter exceptions, execute automatic account posting.
And so this leads us to our first polling question. What is EFT? And we'll give you a minute to make your selection. All right, let's see what you responded. And everyone got that one correct. Number 3 is the correct answer. The use of EFT greatly simplifies cash balancing and control requirements since the cash is deposited directly into the healthcare provider's bank account. It is considered the fastest way to move money. Great job.
And some key points on this slide. EFT is the transfer of funds from payer to payee through the banking system. EFT is the fastest way to move money as the transfer of funds takes place between banks on the same day and the cash is deposited directly into the healthcare provider's bank account. ERA is used to electronically send third-party payment details to healthcare providers. In the cash posting process, each transaction type must be balanced and controlled to ensure that incorrect payments are identified and that the patient's account reflects the correct balance.
And that wraps up section 4.1 and brings us to 4.2, credit balances. In this section, we will address credit balances, why it's important to identify them, and how to resolve them.
And credit balances. Account receivable accounts have credit balances when the payment and contractual adjustment posted to an account exceed the total charges. It is important to identify and resolve credit balances in the accounts receivable for a couple of reasons. If credit balances are not identified separately from debit balances in accounts receivable and the balances are netted, the healthcare organization's accounts receivable level is understated. Credit balances are a liability of the organization and should be reported on financial statements as such. In addition, there are compliance requirements. CMS requires that hospitals report all Medicare credit balance overpayment accounts on a quarterly basis using Form CMS 838, which must be signed and attested by an officer of the hospital, specifically the Chief Financial Officer or CFO, or the Chief Executive Officer or CEO. Finally, states also have reporting requirements related to credit balance accounts. Okay, you're muted.
Sorry about that. Credit balances are created a number of ways. Surprisingly, a large number of credit balances are not the result of overpayments, but of posting errors that must be corrected in the patient account system. Common factors include billing and payment errors and hospital and payer system limitations. Allowance issues usually occurs when there is a payer with multiple health plans and a patient was registered with the incorrect plan type. Large change credits commonly originate from service departments that do not process charges within the organization's suspense days. Corrected claims will have to be sent in those cases. Duplicate payments happen when a provider rebills claims based on non-payment from the initial bill submission. Providers should not be just rebilling when claims are not paid, and most payers do have edits to avoid paying duplicate claims. If accuracy is not focused on when creating estimates, then credit balances will occur, and usually unhappy payments. Until real-time adjudication occurs, this will happen when benefits are checked and then a claim hits against it before yours. This does happen when COB is not coordinated correctly, or if the secondary is not aware of the other coverage, which is typically rare.
For small credit balances under a certain dollar amount, other than patient and federal payers, the hospital should send at least 1 or 2 statements with the following information: notification that a credit balance exists, an explanation of how to request a refund, policy for absorbing small credits if no request is received within a certain time period, and the policy should be matched by a similar policy for small debit balances as well.
And this brings us to our second polling question. Which statement is not true about credit balances? We'll give you a minute to answer. Okay, and let's see what you selected. The correct answer is number 1. Regarding credit balances, there are compliance requirements. CMS requires hospitals to report all Medicare credit on a quarterly basis using Form CMS 838.
And some key points for this section: credit balances occur in accounts receivable when payments and contractual adjustment posted to an account exceed the overall total charges, and credit balances should be identified and resolved to prevent the healthcare organization's accounts receivable amount from being understated.
And we're now going to cover section 4.3, exceptions-based processing denied claims. And in this course, we will address the different types of health plan claim rejections and typical reasons for claim rejections, typical billing errors and how to avoid them, the reasons for health plan denials and how to address and avoid them. And a denial is a health plan's refusal to pay the claim of a healthcare provider. And we're also going to cover appeals and the appeal process, including the Medicare fee-for-service appeal letters. And an appeal is a request by a provider or beneficiary to have coverage and or payment determination reconsidered.
The first thing a health plan does when processing a claim is to check to see if the patient is covered. They are going to look at the claim data to ensure that the date of service is within the dates and all data on the claim matches what is on file, like the name and the date of birth. For example, Medicare will reject a claim if the patient's name and MBI number do not match the common working file or CWF. At my facility in MD, and this was a comment from Christine, they had this happen more often than they liked because patients' legal names were, for example, Harold, but they were registered under Bubba or any other name, for example. Or if it's off by a letter, for example, sometimes they reject it as well.
After the initial claim, the claim is accepted by the payer, but then additional information is reviewed. Things as such, is the service covered by the policy? Is the service medically necessary? Were authorization requirements followed? If not, the claim will be denied. Denials can occur pre-service, at the time of service, and post-service. Technical denial is based on missing or incomplete claim information, such as demographic errors, incorrect or incomplete insurance information, no required authorization or referral, no continued stay authorization, and exceeded frequency limits. A good example is when a mammogram screening is performed more than once within a 12-month period. Clinical denials are associated with the care or service provided and may include the following: the diagnosis does not correspond to the procedure performed, the service is not medically necessary, carve-out days, inappropriate level of care, and the HCPCS code is incorrect for the procedure performed. An underpayment or a payment variance occurs when the health plan does not pay the agreed upon contracted amount. The challenge is that this type of denial is not always recognized during payment posting. This can be incorrect payment rules on the payer or downgrading the service without a corresponding denial reason attached to the line item.
Patient accounting usually has the responsibility to identify and communicate claim denial trends to clinical and operational departments and work with these departments to address and reduce overall denials. To be successful, patient accounting must have a method for identifying and monitoring the denials of an effective process for reversing and eliminating denials. Patient accounting must also understand, track, and trend the reasons for denial.
Some of the previously mentioned denial reasons also relate to inpatient services. In addition, inpatient denials can occur as a result of the following: patient was billed as an observation, but should have been admitted and billed as inpatient. Patient was admitted, but documentation does not support medical necessity. Admission notifications not completed within health plan timelines. Continued care in an acute setting is not supported by medical record documentation. Focused reviews in a specific area that may be related to the use of observation status or the use of anesthesia, etc.
The mission of the RACS is to protect Medicare from fraudulent and abusive billing. When RAC identifies improper payments, They notify the MAC of the applicable claims. The AMC then adjusts the claims to reflect the proper payment amounts. If it's an overpayment, then a demand letter is sent to the provider to recover the payment.
Denials have a significant impact on the revenue cycle. The most obvious impact is the lost reimbursement and increased collection fees, but productivity of staff is impacted as well due to rework, research, and appeal processes.
And I apologize about not being able to see the picture. Reports are an essential tool used to effectively manage denials. Recorded on these reports are information such as denial type, origination of denial or the source, denial frequency. The reports are used to analyze each denial reason and make process changes to eliminate future denials. These reports are also used to track and document appeals and appeals overturned, along with eventual collections.
Denial prevention. So as mentioned, these can happen at 3 different points: the pre-service, the time of service, or even the post-service. So for pre-service, some of the things that we should do are gather complete and accurate demographic and insurance data, complete insurance verification for all insurances listed on the account, not just the primary, understand health plan requirements, complete medical necessity screening, obtain all required authorizations, and communicate to all staff involved. Time of service, we should provide only ordered services, closely monitor patient services, and verify that all services ordered and provided are clearly documented, code accurately based on documentation, and again, communicate to all of the staff that's involved. And post-service, complete pre-bill and the edit processing, categorize and analyze denied payments to prevent future denials, monitor denial activity and final appeal outcomes. And just as with the others, communicate with all of the staff that's involved.
Any individual dissatisfied with the government or health plan claim determination is entitled to reconsideration of the decision, with Medicare having clear guidelines and structure around those. Medicare also has specific rules on provider appeals as well. Waiver of liability refers to a provision established by Medicare to protect beneficiaries and physicians from liability when services are denied as inappropriate or medically unnecessary. If the Medicare beneficiary had knowledge or should have had knowledge that they were not covered, they can be billed. If neither the patient or provider knew or reasonably could have been expected to know, Medicare is liable to pay the claim. If the provider should have known or did not inform the beneficiary may not be billed. Medicare beneficiaries and providers have extensive rights to appeal individual coverage determination.
And so the medical appeal process can occur different ways, by the Medicare Appeals Council, by a qualified independent contractor, through a hearing before the administrative law judge, reviewed by the Medicare Appeals Council, and judicial review by a federal district court.
For non-government claim denials, providers must follow the appeal conditions specified in the individual health plan contracts. Sometimes these appeal requirements are provided in the contract, but if it isn't clear in the contract, the appeal requirements can be obtained from the health plan that issued the denial. Appeals must be submitted within the time frame outlined in the contract, and an appeal to the health plan's chief medical officer may be pursued as an appeal of a final and last resort. Patient account staff can obtain the assistance of the beneficiary if proper authorization is obtained from the patient to facilitate the appeals process if the patient's account staff are experiencing difficulty obtaining a response from the health plan. And in all situations, the patient's information must be maintained in a confidential manner.
And here this brings us to a polling question. Which option is not a type of denial? Okay, let's see what you responded. So this was a tricky one. And the correct answer is number 2. This is the part of the patient's bill that a provider must write off because of contractual arrangements with the health plan, the contractual adjustment.
And some key points for this section. Providers must implement denial appeals when health plans have incorrectly denied or incorrectly paid claims, and beneficiary appeals and provider appeals are 2 types of appeals.
And our last section for today, 4.4, exceptions-based processing on not paid claims. In this section, we'll take a look about follow-up procedures for unpaid claims and common account resolution procedures.
The clean claim payment cycle should be determined for all major health plans. For example, Medicare pays clean claims within 14 days. If not received within that time frame, follow-up should begin. Additional follow-up will be queued based on the initial follow-up response. When primary payment is received, the actual reimbursement is compared to the expected reimbursement. Any remaining contractual adjustments are posted. If applicable, any secondary claims are submitted unless there's an automatic crossover provision from the primary payer to the secondary payer. If there are no additional third-party payers, any self-pay balance will be billed to the guarantor.
In addition to utilizing real-time work lists to identify claims that have not been paid within the expected timeframe, there are a number of claim follow-up tools and techniques that can assist in identifying potential non-paid claims sooner. Many larger health plans accept electronic claims directly from the provider or via clearinghouse. In addition, they may offer daily claim acceptance and validation real-time feedback so that immediate same-day action can be taken by staff if a submitted claim is not accepted by the health plan. Additionally, the health plan may provide an online portal whereby the provider can track the status of individual claims within its claim processing system. If a clearinghouse is used to submit electronic claims to third-party payers, daily claim transmission files are confirmed, and payer acceptance of individual claims is often available via a daily clearinghouse, electronic work list, or report. The reason the claim was not accepted is also communicated, and immediate same-day action can be taken by staff to resolve the issue. The Medicare Common Working File, CWF, is a host of databases that houses all beneficiary claim history and entitlement information. All Part A and B claims for a beneficiary are processed against a single file prior to claim payment. The record is updated daily with data from adjusted and approved claims, including basic reply communications such as if it's accepted as is, or payment is adjusted and then accepted for payment. If there's a cancel or void claim, accepted or rejected and not in the host file. And lastly, MSP maintenance response.
Priorities should be set for follow-up. Typically, 15 to 20% of accounts make up 80% of the accounts receivable dollars. Staff should focus on the high dollar balances to quickly reduce their receivables. To ensure work is being completed, real-time work in process, WIP, reports should be tracked with standards set for staff follow-up productivity and quality. Payment turnaround techniques are, for example, the use of electronic claim submissions, send hard copies of claims via overnight mail or same-day courier, send high-dollar hard copy claims via registered mail with required attachments until the electronic attachment standard is implemented, and closely monitor payment timelines and backlogs of major health plans. The following are additional key focus areas, which, if not properly managed, result in delayed third-party payer account resolution. Unbilled backlogs for unverified insurance coverage, coding processing backlogs, missing or late charges, resolved pre-bill edits, final bill not submitted to payers or holding and claim scrubber, or billed but unpaid claims. Billed but unpaid claims.
Liability payers. Confirmed liability payer has primary responsibility to pay for healthcare services. Liability payers include workers' compensation, which are responsible for work-related accidents and injuries. Primary responsibility for all covered work-related services. Medicare will not pay a secondary for covered work-related services. Automobile medical insurance, responsible for healthcare services that result from an auto accident, and most health plans will pay as secondary after the auto medical benefits are exhausted. And premises medical coverage. This insurance covers accidents that happen on a business or individual's property and covers visitors, employees, and animals. Residents are not covered, but instead are generally covered by their own health plan. A lien is a claim against real or personal property that secures payment for a debt or performance of some other act. A lien gives a creditor the right to have his or her claim satisfied from the specific property that is subject to the lien before the property can be used to satisfy the claims of general creditors. In healthcare, liens are typically used to secure payment from motor vehicle accidents and other liability claims. Liens are treated in several different ways.
And this brings us to another polling question. Which option is not a lien type? We'll give you a few seconds to answer that. We're 50-50 right now. Okay, and yes, most of you answered subrogation, and that is the correct answer. Subrogation is not a lien type, but instead a process used to pursue payment.
So as we wrap up today's session, we're going to review some key points for section 4.4. The third-party payer follow-up and account resolution activities include generating a real-time electronic work list after untimely payments, comparison of actual and expected reimbursements, adjustments, post, submitting secondary claims if necessary. Based on an organization's policy, and an unpaid clean third-party claim may become the patient's responsibility a specific number of days from the initial bill date unless prohibited by a managed care contract or acceptable state and or federal regulations. And lastly, workflow payment cycle. The clean claim payment cycle should be determined for all major health plans, and if timely payments are not received, such as Medicare pays clean claims within 14 days, a real-time electronic work list should be queued in to initiate immediate follow-up.
And I believe that wraps up our session today. We thank you for attending, and again, we apologize for that initial technical difficulty. We hope that you learned from today's session, but please remember to go ahead and complete the section on your own through the HFMA website, and also conduct your own study, as this session alone will not prepare you for the exam. And so thank you again for joining, and we hope you have a good rest of your week.
Thank you, everyone.